Hi there, I'm Dr. Damon Scales. I'm an intensive care doctor at Sunnybrook and a scientist at Rescue. I've come today to talk about the ICEPACS trial. Why do I care about the ICEPACS trial as an intensive care doctor? I honestly believe that you as medics can have a profound impact on our patients by starting the cooling process earlier in the field before patients hit the hospital. Just to remind you, why do we think cooling is so helpful? There were two landmark trials in the New England Journal of Medicine more than 10 years ago that showed that for every 5 patients that you cool, 1 more patient survives to have a good neurologic outcome. That's an incredible result. To put that in perspective, we got rid of streptokinase in the entire system in favor of using TPA for acute myocardial infarction because of a number needed to treat of 100. By comparison, cooling a patient after they have successful return of spontaneous circulation is by far one of the most powerful interventions we have in medicine. The ICEPACS trial is an individual patient randomized trial in which one half of the patients will receive cooling by medics in the field and the other half will just receive usual care by medics. I believe the most powerful aspect of the ICEPACS trial will be that your intervention, cooling someone in the field, will help remind clinicians that this is an important treatment and it will be continued without delay in the hospital. Earlier cooling might actually help us get patients down to that target temperature of 32 to 34 degrees in a much more timely fashion. There have been previous studies of cooling, but they've all compared cooling in the field to cooling in the hospital, where 100% of patients get cooled in both groups. This is very different than the ICEPACS trial. The ICEPACS trial is really testing whether earlier cooling by all of you can help make sure that these patients get the treatment in a more timely fashion and that clinicians in the hospital remember that this is a time-sensitive, important treatment that our patients need so that they can have a good outcome. Are there any risks to cooling? There are, but the treatment is surprisingly well tolerated. By far the most commonly encountered side effect is shivering. From a practical standpoint, this is more of a nuisance for us because we have to overcome that shivering response to get someone into the target temperature of 32 to 34 degrees. Other side effects include sinus bradycardia, cold diuresis, and electrolyte disturbances, but most of these don't become a problem until about 10 to 20 minutes after the patient's been cooled, and therefore are more likely to be something that the in-hospital clinicians encounter. Who should be cooled? Well, first, it has to be someone who's been resuscitated from a non-traumatic cardiac arrest. We define this as someone who's received CPR or defibrillations by anyone and has had a successful return of spontaneous circulation. They should have had sustained ROSC for at least 5 minutes. We're asking for that 5-minute delay because we believe that after the 5 minutes, patients will be much less likely to re-arrest and more likely to be able to tolerate the treatment. They should be adults, they have to be normotensive, and this highlights an important point. When we're prioritizing treatment goals in someone after a cardiac arrest, remember, perfusion of the brain is our top priority. Without an adequate blood pressure, cooling doesn't matter. So all patients should have a systolic blood pressure of more than 100 before they're randomized. They should be unresponsive to verbal stimuli using the AVPU scale and intubated as well. Finally, they should be adults, and only patients randomized to cooling as part of the ICEPACS trial are currently eligible for cooling in the region. Who shouldn't be cooled? Obviously, if your patient has had a traumatic cardiac arrest, if they've been found with exposure hypothermia as the cause of the arrest, or if they have severe bleeding, they shouldn't be cooled. Severe bleeding is a contraindication because cooling can theoretically impact on your coagulation system. Similarly, if patients are receiving dabigatran or Coumadin, they shouldn't be randomized in the ICEPACS trial. Finally, like all of our trials, patients should not be randomized if they're known to have a verbal or a written DNR, if they're prisoners, or if they're pregnant, because we believe that doing research on these patient populations has ethical challenges. The randomization procedure is quite simple. On the trucks, there'll be an envelope that looks like this. In fact, there'll be one of these in the ALS medication kit, and there'll be another one in the drug cupboard. You'll open the envelope, and inside will be a card that says whether you should randomize the patient to cooling or not cooling. If the patient is randomized to no cooling, this means that you just continue your usual excellent post-resuscitation care, but cooling should not be provided. Inside of the envelope, there'll be a mock wristband. I'll talk more about that in a minute. The mock wristband for when patients are randomized to no cooling should simply be discarded. In addition, there'll be a simple chart insert that you can pass on to the in-hospital clinicians just to notify them that your patient was randomized to no cooling in the field. If they're randomized to cooling, inside the envelope there'll be a card that says, "Please cool the patient." There'll be a wristband and an ankle band that should be affixed to the patient's wrist and to their ankle, and these are intended to remind the in-hospital clinicians that the patient's been cooled and that cooling should be continued. The next thing that you should do if they're randomized to cooling is to give 5 milligrams of midazolam. Midazolam is given to overcome that shivering response that we know people are likely to encounter when we start to drop the body temperature. Next, after the midazolam has been given, you open up the cooler and you take out the frozen gel packs. There should be 4 frozen gel packs that look like this, and these should be placed in order of preference on the carotid, in the axilla, or on the groin. We don't really care where you put them as long as they're put bilaterally and in a place where you think they're likely to stay in place. Next, you take out the 2 liters of cold saline and the cold IV tubing that's been kept in the cooler. The cold saline is intended for infusion, and of the interventions we're giving in the field is by far the most powerful intervention for actually dropping the patient's temperature. We keep the tubing in the cooler because we know that there is significant cooling loss as the tubing warms up the IV fluid en route from the bag to the patient. Therefore, it's preferable that you use cold tubing to infuse the cold saline. One more word about midazolam. So the midazolam is used to prevent shivering. Under the current medical directive, you can give up to 10 milligrams of midazolam if you need to prevent shivering. If you feel that your patient needs more than 10 milligrams, you can always patch in to obtain an order for more midazolam. Finally, remember that midazolam can sometimes drop blood pressure, so the midazolam should not be given unless the systolic blood pressure is more than 100. The other important clinical considerations again relate to making sure that your patient has adequate cerebral perfusion pressure. If your patient doesn't have an adequate blood pressure, you're still resuscitating the patient, and cold saline and cooling should always be considered a post-resuscitation intervention. For this reason, all patients should ideally have a second IV that can be used as a dedicated line for the cold tubing and for the cold saline. If you're only able to get one IV and the patient needs blood pressure support, then that takes priority over cooling, and dopamine should be used in priority over cold saline. However, if there are 2 IVs in place and you're running dopamine in one, you can use the second IV to run the cold saline. What happens if you can only get one IV? It's fine to use it for the cold saline even if it's room temperature tubing, so long as the patient's blood pressure is maintained. To emphasize this point again, dopamine always requires a dedicated line, and if you can only get one IV and your patient's needing dopamine, use that line for dopamine and not for the cold saline. However, you still can apply the surface cooling and the wristband and the ankle band to the patient, which will still help to cool the patient and also to warn to notify the in-hospital clinicians that your patient's been cooled. What happens if your patient has an arrest? In the event of a rearrest, stop the cold saline infusion. Again, you can continue the surface cooling and leave the wrist and ankle band in place. If your patient develops a drop in blood pressure below 90 millimeters of mercury, then you should also stop the cold saline. However, if you're able to resuscitate the patient to having a blood pressure above 90, you can resume the cold saline again. Again, in this situation, it's okay to continue the surface cooling and to keep the wristbands and the ankle bands in place while you're waiting for the blood pressure to be restored above 90. When it comes to restocking, Randomization envelopes are kept in the drug cupboard, and these should be restocked in the same manner as narcotics. Remember that one envelope should always be kept in the ALS medication bag, and another envelope should be kept in the drug cupboard. The cooler will be fastened to the EMS vehicles. At the beginning of every shift, take 4 new frozen gel packs from the freezer and place them in the cooler, replacing the thawed gel packs. In addition, take out 2 new bags of cold saline from the fridge and replace the warm saline bags that were in the cooler. Always remember to leave IV tubing in the cooler so that it can be kept cold along with the cold saline. Finally, the most important part of the trial to make it successful from a research standpoint is to ensure that we have some information about the randomization procedure. The most important information to record on the EPCR is the randomization number. If you don't have the randomization number, we won't be able to follow the patients to ensure that they've had the good outcome that we anticipate. Finally, if they're randomized to cooling and something happens so that cooling has to be stopped, we'd also ask that you document that so that we can track any potential harm or unintended consequences from this approach of starting cooling in the field. That concludes my presentation about ice packs, which I honestly believe is one of the most exciting trials that Toronto's participated in. Remember, we do this research to help our patients. It's voluntary from start to finish, whether it involves paramedics in the field, nurses in the emergency department, doctors in the intensive care unit, or researchers like me. We're all in this together, trying to improve the outcomes for our patients. If you have any questions about the trial or want to discuss any aspect, you can always reach out and talk to me. My email is damon.scales@sunnybrook.ca, and my phone number at Sunnybrook is 416-480-6100, extension 83734. I look forward to hearing from you, and I look forward to successfully completing this trial along with all of you. Thanks.